Welcome, I'm Marie Harvey, and it's a pleasure to see all of you here. And I'm going to introduce Carrie Lynn, who is an assistant professor in our health promotion health behavior program, who will introduce our speaker. Or maybe you'd like to introduce somebody else.
I think we're all excited to be here to welcome Dr. Sarah Dermody. She is a new assistant professor in the School of Psychology, but she received her Ph.D. from University of Pittsburgh. Sorry, I forgot. No. She received her Ph.D. from the University of Pittsburgh in clinical and biological and health psychology. Her interests, she has multiple funded grants, but her interests lie in characterization of risk of alcohol, cigarette, and marijuana use, independence across the lifespan. She's also interested in optimizing addiction interventions to address co-occurring substance abuse. And I think it's really timely to have you here, and we look forward to your presentation.
Thank you. Thank you for inviting me here to speak. A lot of my interests are very closely related to public health, and over the past few weeks, several people have reached out to me from this school, and it's been really welcoming, so I really appreciate it. So today I'll be talking about alcohol and cigarette use and co-use. And I'll start with just a bit of background, fairly brief, talking about why I'm interested in this area. And then I'm going to focus most specifically on what are the effects of some of tobacco-related policies on alcohol use, and how I've been able to use these policy-related contexts in order to look at some of the mechanisms that relate the use of one substance to the other. And then, as Carrie Lynn mentioned, I'm very new here, and so I'm just starting to build my lab and some of the projects I'm working on. So I'm going to talk about briefly some of the studies that are really in early working that I would love to have collaborators on if there's anybody interested in the projects. As many of you probably know, smoking and alcohol use are two of the top modifiable, preventable risk factors for death in the U.S., with smoking really leading the way. Current estimates of about 480,000 people, adults in the U.S., dying each year just from tobacco-related deaths. When I accepted the job here and I moved here, I heard many times, oh yeah, people don't really smoke in Oregon. Drug use isn't really a problem there. Everybody's healthy. But as it turns out, I don't think I have to convince the people in this room, but I found that these handy numbers actually show that tobacco use is the top preventable cause of death in the state of Oregon, with 7,000 people dying each year for tobacco use. And alcohol use, while numerically is quite farther behind, it's one of the top contributors to death in Oregon as well. While both the use of tobacco or alcohol in of itself are really important areas to study and to try to mitigate the use of these products, what is becoming increasingly clear is that the use of each of these products are not independent from each other. So oftentimes we see heavy drinkers being heavy smokers and vice versa. So about 15% of adults in the US are estimated to be both using cigarettes and alcohol. So I'll be referring to these individuals as co-users. And what do I mean by that? Well, I mean that they report recent use of both substances. I'm not really talking about momentarily that they're using them at the same time, but from what we know, usually that's what's happening, is that people are smoking and drinking together, at least many of the occasions. And then when we're looking at heavy drinkers and problematic drinkers, we see quite high levels of cigarette smoking. So about 50% of heavy drinkers report using cigarettes in the past month. And the numbers are very similar when we're looking at people with alcohol use disorder. So not only is co-use rather prevalent, but we see that using both of these substances even lead to a greater negative health outcome. And in some cases, we see actually a synergistic effect. So for instance, for the risk of some cancers, it's beyond just adding the risk of tobacco use and alcohol use to understand what the cancer risk is associated with being a co-user. We actually see an even magnification of the risk. We also see that people who use both substances have greater risk of psychiatric comorbidity versus people who only use one substance. And they also have a harder time quitting using the substances. So in my work, I truly try to understand what is it about these substances that make them go so well together? So what is leading people to use cigarettes with alcohol? With the idea that by understanding these relationships, we can better help people who use both of these substances. So I recently published a review paper that focused on laboratory-based studies that effectively had people administer nicotine products and then looked at their alcohol use, or had them administer alcohol and then looked at their tobacco use to really try to get at this causal relationship here. And what I found in reviewing this literature is that quite consistently, greater alcohol exposure in the laboratory leads to greater subsequent tobacco smoking and nicotine administration. Interestingly, the other relationship going the other way around is a little bit less consistent. So while in some studies we do see that exposure to nicotine increases alcohol use in the laboratory, there are a lot of studies with null findings. That being said, there are a lot of inconsistencies with the methodologies. So for instance, like what kind of participants they're recruiting, how is nicotine being administered? Is it through a cigarette or a patch or even a lozenge? So it's hard to know exactly why those inconsistencies are in place, but in my work, I'm trying to better understand, what is the nature of this relationship. I'm also really interested in how there may be shared risk factors that simultaneously increase the risk of using either substance, and then as a consequence can increase the risk of co-use. So one of these risk factors in particular are related to stress. So understanding how certain stress-related experiences might increase the risk not only of alcohol and tobacco use, but also the use of both of these substances. I'm actually going to be talking very little about this research today. So in this work, I looked primarily at certain disadvantaged groups that are at risk for being victimized and how that relates to polysubstance use patterns. So I do a lot of work focusing on sexual minority youth, lesbian, gay, and bisexual youth. So I won't be talking about that today, but if anybody's interested in that work, I'm happy to talk about that further. The other thing I want to point out is that these relationships are truly bidirectional, and while it looks like a pretty simplistic explanatory model here, when we try to actually tease apart these relationships, it can get rather complex because of these bidirectional relationships. Well, in my research, what I try to look at then is what are the processes affecting alcohol or cigarette use as well as their co-use, who's at risk for using these substances as well as co-using. And the whole point of this, again, with my background being in clinical and health psychology, I'm really interested in improving health. So I want to be able to translate this information into effective interventions to help co-users. Well, when I do this work, I really consider multiple levels of analysis. So I do laboratory-based studies, I do epidemiological studies, and I do policy-related work. So today, I'm actually going to be, given my audience, focusing more on the policy-related work that I've done. I'll briefly mention some of the more individual-related work as well. All right, so where I want to start is talking about how nicotine-related policies that might be meant to reduce tobacco use can impact alcohol use as well. Some of you may have heard this recent announcement. The FDA Commissioner Scott Gottlieb announced that the FDA is taking the initial steps towards taking regulatory action of nicotine in cigarettes. So since 2009, the FDA has had the regulatory authority to reduce the nicotine content of cigarettes to very minimal levels. It can't be zero, but a small amount of nicotine. And now, 2018, they're actually starting to take action. So presently, they're accepting public comment on this type of policy, but leading up to now, there's been considerable research trying to understand whether such a regulatory policy would be beneficial to public health. The whole premise of this type of policy is that nicotine is the primary addictive substance in cigarettes, and if we can reduce cigarette nicotine levels to a non-addictive level, then people would ultimately reduce their smoking levels, and it should hopefully help them quit smoking. In order to do this research, we use investigational cigarettes with very low nicotine content, so I'll be referring to these as VLNC cigarettes today. And these cigarette nicotine levels are considerably lower than what we would see in a conventional cigarette being sold in the market. And initial clinical trials that have randomly assigned people to smoke these cigarettes as opposed to normal nicotine content cigarettes have found that when people switch to these cigarettes, not surprisingly, they demonstrate an immediate and substantial reduction in their nicotine exposure. So that's based on biomarker measures. They also show gradual reductions in their cigarettes per day. So these changes are statistically significant. They tend to be modest. We're talking about in a 6-week period, maybe a reduction of about 5 cigarettes per day on average, which depending on the sample, that's about like a 30% reduction. And then a concern of this regulatory policy is, well, if we take the nicotine away, are people going to feel really uncomfortable due to withdrawal symptoms? So for instance, things like restlessness, impatience, trouble concentrating. And pretty consistently, we're seeing in these studies that actually smoking these cigarettes or switching these cigarettes doesn't substantially increase withdrawal. Why might that be the case? Well, first of all, there's still a little bit of nicotine, and we don't know a whole lot about how much nicotine it really takes to regulate withdrawal symptoms. So it might be that that's just enough. We also know, however, that just through learning processes, there's this association between the cigarette and nicotine. And when people smoke the cigarette, even in the absence of nicotine, they experience diminished withdrawal. And that might just be because of a learning process. Now, where I kind of entered this regulatory field is recognizing that smoking and drinking are two closely related behaviors. And many people had concerns that, well, what if we make nicotine an unavailable substance? Is that going to just make people compensate with drinking more, particularly if someone is a co-user? So what I wanted to examine in this work is really trying to understand, are there any unintended consequences of nicotine reduction, like policies, on this health behavior of alcohol use? At the time when I first raised this question, there hadn't been any research or research data directly to speak to this. So what I did was I conducted a review paper to try to indirectly determine what we might predict would happen. So how I did this is that first I described what we knew already about the relationship between smoking these valency cigarettes on various intermediate processes that might relate to alcohol use. And as I described just a moment ago, what we know is that individuals who use these cigarettes as opposed to a normal nicotine content cigarette, they have reduced nicotine exposure, they reduce their smoking, and they tend not to have withdrawal symptoms. And then there have been numerous laboratory studies that have looked at the relationship between nicotine exposure and alcohol use. And so I was able to then also describe what might those changes, how might they correspond with changes in alcohol use. So generally speaking, I mentioned earlier there's some inconsistencies, but nicotine exposure tends to increase alcohol use. They tend to be complementary. It's also possible that cigarettes, independent of the nicotine, would increase alcohol use. Why is that the case? Well, one reason, because of the learning processes I mentioned earlier. So if people just tend to use these together, they might just learn to associate them. So just having a cigarette around them might lead them to crave alcohol, even if they haven't even smoked it yet. So might that also play a role here? And withdrawal could lead to increases in alcohol use if people want to try to cope with it. So that was maybe the one mechanism that would lead to compensatory drinking or that unintended consequence. But given that these cigarettes tend not to increase withdrawal, I expected that this wouldn't lead to an increase in alcohol use. And instead, there may actually be overall reductions in drinking because of these reductions in nicotine and cigarette exposure. So this would lead to an overall negative negative statistical association, but a very hopeful outcome when it comes to alcohol use. So I was able to finally get data to test these relationships for the first time as part of the Center for Evaluation of Nicotine in Cigarettes. So this was a multi-site effort. The primary aim of the study was to look at varying levels of nicotine in cigarettes in order to look at what would be the optimal dose for this type of regulatory policy. And then I was just that person that was like, well, we need to measure alcohol use. And so we added some really in-depth measures of alcohol use as well so that I could look at some of the mechanisms I'm describing here. So I'm going to describe analyses from a subsample of adult daily smokers who were also alcohol drinkers. So this is about half of the total sample that participated in this study. They were on average about 40 years old, 40% female. We had about 60% who are non-Hispanic white. They were smoking about 15 cigarettes per day. They were also generally lighter drinkers than we would expect in a smoking sample. And that's partly because of the inclusionary criteria for this study. We excluded people who were particularly heavy binge drinkers and anybody that appeared to be alcohol dependent. So that's something to keep in mind. That being said, we still had about 20% of these individuals reporting what we understand to be high-risk drinking, and there was some problematic drinking in the sample. Well, what did the study look like? Well, we followed participants for a 2-week baseline period where they smoked their typical cigarettes, and we conducted various measures. But then they were randomly assigned to smoke one of 7 cigarette conditions for the duration of 6 weeks. And during that period, we were assessing daily alcohol and cigarette use, nicotine exposure, and withdrawal symptoms, so the mechanisms that I described earlier. So this was a double-blind randomized clinical trial with the exception of one of the conditions. So there was the lucky subgroup that got to keep smoking their normal, their usual brand of cigarettes, and we provided it to them free of charge. So there's this interesting phenomenon that it's not surprising, but there was like an overall increase in smoking in that group because they weren't limited by price. We would give them as many cigarettes as they wanted. But in this particular analysis I'm going to describe, I'm going to be talking about a control condition that had normal nicotine content cigarettes. So this is not their usual brand of cigarette, but it had normal nicotine content, versus all of the very low nicotine content cigarettes combined. So the reason I have combined them for these analyses and what I'm telling you about now is that I did look at them separately. They all behaved very similarly, so it gave us more power to look at them together as one group. So in order to look at these mechanisms that I described, I used parallel process models, basically looking at the trajectory over the 6-week period of the mediators of interest. So for instance, how cigarettes per day changed over the 6-week period, and then how that related to the changes in alcohol use. And with all that, to just understand how might valency cigarette use be related to the changes in alcohol use over time. In light of the concern that there might be some subgroups that might show compensatory drinking, even if we don't see an overall negative effect, I also considered several moderating variables, so things like sex, baseline smoking level, baseline drinking level, presence of alcohol-related problems at baseline, to see might there be a subgroup that we need to be concerned about. Just to kind of highlight the significance of doing latent growth curve models in this data set, this is a random sampling of 20 participants, and it shows their alcohol use over the course of the 6 weeks. As you can see, at week 0, so baseline, there's just a lot of variability there, even where people were starting out. And then even as you look over time, there's a lot of variability in terms of what the change patterns were. So when I ultimately evaluated what was the best fitting average typical curve for this data, I supported a piecewise functional form. In other words, during the first 2 weeks, we saw a slight increase in drinking overall in the sample. However, during the last 4 weeks, on average, there was no change in alcohol use. That being said, there was a lot of variability in the last 4 weeks of alcohol use. And so it was important to try to understand who might be increasing and who might be decreasing. This is a depiction of what the parallel process model looks like. I'm not going to spend much time on here. I'm just going to demonstrate that with this change in cigarettes per day, I'm taking into account the change in the cigarette smoking over the 6 weeks, same with the alcohol use. But I'm separating the change in these two processes by the first 2 weeks and the last 4 weeks, just based on what I saw with the alcohol use. Okay, so here are the results. As expected, individuals who smoked the valency cigarettes as opposed to the normal nicotine control condition showed significant reductions in cigarettes per day in the first 2 weeks as well as the last 4 weeks. In addition to that, we saw significant relationships in the change of cigarettes per day and the change in alcohol use over time, specifically in the last 4 weeks. And it was in the expected direction. So what we saw was that individuals in the valency cigarette condition tended to reduce their cigarette use, and in turn, they showed reductions in their alcohol use as well. We saw a very similar pattern of findings when looking at nicotine exposure. So again, individuals assigned to smoke very low nicotine content cigarettes had significant reductions in their nicotine exposure based on biomarker measures. However, at the last 4 weeks, reductions in nicotine exposure were associated with reductions in alcohol use as well. This is where we saw a couple moderators, but by and large, like across these analyses, we didn't support many individual differences based on the variables I described. So we did see that women had greater nicotine reduction than men. Based on some subsequent papers we've done with this data set, we suspect it's related to compliance. Women tended to comply better with these cigarettes than men did. Also found that people who had symptoms of problem drinking had a stronger relationship between nicotine exposure and alcohol use. So gut reaction might be like, oh no, this is a subgroup that's drinking to cope. We're really worried about them. But actually, it's in the direction that they benefited the most. So individuals who were problem drinkers had, when they had reductions in nicotine exposure, they had even greater reductions in their alcohol use. As I mentioned earlier, these cigarettes still contain some level of nicotine. So given that the pattern of findings were effectively the same for cigarette use and nicotine use, it was really important to try to determine whether that cigarette effect might be a nicotine effect because of the small levels of nicotine. So to do this, I looked to add them simultaneously as mediators, basically co-varying for a nicotine effect when looking at the cigarette effect. And in doing so, found that the change in cigarette use was related to alcohol use over and above the effect of nicotine. So it didn't appear to be solely explained by nicotine. So in this case, the hypotheses were supported. We saw that smoking these cigarettes corresponded with reductions in nicotine and nicotine and cigarette use. And in turn, given these positive relationships, we saw reductions in alcohol use as well. So just kind of putting this in the context of some of the research questions I presented with you earlier, it appears that cigarette use may impact alcohol use both through nicotine exposure as well as potentially through cigarettes, independent of the effect of nicotine. When trying to understand who's at risk for co-use, this data provides one potential individual difference of interest, and that was that the problematic drinkers showed a tighter connection between nicotine and alcohol use. And then how do we intervene with co-use? Well, this suggests that maybe just, a nicotine reduction policy, so some of the interventions that we do to try to reduce tobacco smoking may have added benefits of reducing alcohol use patterns as well. Okay. So as I mentioned, a limitation of this study is that we were excluding heavy drinkers. And earlier I talked about how 50% of heavy drinkers are cigarette smokers. So we are really interested in understanding how we can intervene and deal with tobacco use among heavy drinkers. So some of the subsequent work that I've done is trying to examine specifically among heavy and problematic drinkers, how might we intervene with tobacco use. So I've recently learned about some of the tobacco-free initiatives coming into play here at Oregon State University. Before coming here, I was at the Center for Addiction and Mental Health in Toronto. And while I was there doing my postdoc, they were similarly going through a transition from a smoke-free hospital to a fully tobacco-free hospital. And so I was engaged in some research at the time, trying to evaluate exactly what the staff attitudes were, the patient attitudes were to this change, as well as understanding how these changes would be influential among individuals who are getting inpatient treatment for other substance problems. So just briefly, tobacco-free policy involves a ban of all tobacco-containing products on a premises, and this can be contrasted with a smoke-free policy that's really just banning cigarettes. And at this hospital, they had started out with a partial smoking ban in 2005, and then they had this soft launch for a tobacco-free policy in 2013. Basically, they were just in the process of warning everybody that the tobacco-free policy was about to happen without actually having officially made any changes. But then in 2014, that's when the hard launch came and the hospital became fully tobacco-free. So over the course of these changes, we were sure to try to assess some of the staff and patient attitudes. Because going into doing this tobacco-free policy, there were just concerns that people would hate it and wouldn't tolerate it. But what we found is that staff were generally very positive about the policy throughout the 3 periods of rolling it out. The few exceptions, so we had like 15 items, and really all of them were on the top of being positively rated. But the few exceptions were that staff had reported that there may be more that needs to be done to actually reduce tobacco use and secondhand smoke exposure, so that there might be some non-adherence happening. Smoking staff, which was about 9% of the survey participants, tended to have less favorable attitudes than non-smoking staff, particularly with respect to what the benefits of the policy would be, as well as might there be stigmatization that occurs against people who smoke. Patients also had very favorable views of the policy, and they also had some concerns about adherence and what the policy would be able to offer in the future. A concern that came up, and does come up when these types of policies get rolled out in hospitals, is might there be like a revolt, or might the withdrawal that comes from depriving people of tobacco products lead to so much irritability that might actually increase violence. So we did look at violence-related incidents at the hospital over the course of launching this new policy. And what you can see here on the y-axis is the average weekly number of incidents, and on the x-axis is when we were pre-tobacco free, the soft launch of tobacco free, and then when we were actually at the hard launch. And there was a significant reduction in these incidents over time. Now, of course, I can't say that this is due to the tobacco-free policy. However, I guess what I can point out is that the time frame's about the same, and we didn't see an increase. So we didn't see the rioting and high levels of irritability that would produce violence that some people had feared. One thing that I thought was really interesting, however, is that even though, as I mentioned, there was this hard launch of the tobacco-free policy, there were still informal exceptions, one of them being the inpatient addictions unit. So this is an inpatient addictions unit, and this is actually a picture of where the patients would leave the unit to smoke. And at the time, I was doing research with these participants, so I saw that they were actually able to maintain their normal smoking levels even though they were admitted as inpatient for addiction. So they would just go have a smoking break, and then they would come back to their treatment. So, it was convenient for me as a researcher that was happening, I guess, in some ways, but it was really kind of concerning because here we have individuals coming for treatment for addiction, and we're completely ignoring the fact that they're also tobacco dependent, and that's likely the thing that's going to be contributing to their premature death. And the thing is, this is not an issue that's isolated to this specific hospital. It's a widely held concern by staff members that tobacco-free policies are incompatible with inpatient addictions units. Some of the concerns are, we don't have the capabilities of helping them with tobacco use. They should just be worried about one substance at a time. If you try to deal with both at the same time, then they're going to have worse outcomes. Then there's concerns about whether patients would be upset if they were not allowed to smoke, and might that create further problems. But the thing is, what we know from the research that's been done in this area is that none of these concerns are empirically substantiated. In fact, we see that intervening with the use of both of these substances at the same time can lead to comparable outcomes in terms of treatment, or even improved outcomes. So we're not seeing that by having people address both their tobacco use and their alcohol dependence at the same time, that they're worse off. We actually see them being better off in many cases. Well, while I was there, I caught wind accidentally that they were going tobacco-free, that this unit was becoming a closed unit, and that people would no longer be allowed to smoke. So I decided that this would be a great time to actually collect some data to see, are some of these concerns valid that people have with respect to implementing tobacco-free policies in these settings. So what I tried to look at is what are some of the overall treatment outcomes in the context of having a tobacco-free setting with inpatient addictions treatment. Looked at what might be the client adherence patterns and what are their general views of the tobacco-free policy, and then looked at the impact of being admitted in such a setting on tobacco-related outcomes. Now, to look at this, I use a simple survey design, which participants were able to complete the survey when they were admitted, as well as when they were discharged about 2 to 3 weeks later. What I really wanted to do was able to have this data before the tobacco-free policy happened, as well as after, so I could actually look at what the differential treatment outcomes would be. Unfortunately, with the timing of when I finally found out this was happening and then how long it took for me to get ethics approval, I only got a few participants before they actually made the change. So I'm only going to be talking about data from after the tobacco-free policy was implemented. Just to give you a sense of some of the measures, measured demographics, dependence to various substances, what were their treatment goals coming into treatment as well as when they were leaving, drug use patterns, craving, mental health, withdrawal, what were their goals related to quitting smoking, what were their experiences with smoking-related treatments during their admission, and what was their treatment satisfaction. I have data from about 100 participants from the inpatient unit, and what you can see is about 60% of them were cigarette smokers. So, I mean, I didn't try to get more cigarette smokers. This is just fairly representative of what we're seeing when people are coming to inpatient treatment at this hospital, is that most people are cigarette smokers. They were middle-aged. The sample is more male than female. They were highly alcohol dependent. And a few things I want to talk about is that the smokers actually showed higher levels of alcohol-related problems than the non-smokers. And I actually have a student that's tried to analyze a bit more to understand what is going on there. And what's interesting is that at admission, the smokers and non-smokers report very similar levels of drinking, but the smokers report greater problems related to their drinking, more impaired control, more consequences. So it's a question of whether there might be something related to the smoking that, or their susceptibility to smoking that makes alcohol dependent symptoms even worse. The smokers were also entering with greater psychological distress compared to non-smokers. Okay, so when I had talked to staff members in the process of developing this survey, I don't have data on this, but I can just describe some of their views. But many people had expressed that they just didn't think that people were interested in quitting smoking, that they were coming into treatment for a substance and it wasn't tobacco. What was interesting is that the majority of patients were coming in for alcohol-related problems, but the second most commonly reported product of concern was tobacco. So this is not a tobacco treatment clinic. People are coming for treatment for other substances, but many people are coming in saying that they want help for their tobacco use. And the vast majority of them reported at least one quit attempt prior to being admitted. When looking at the discharge survey, I asked the patients, the smoking patients, what were their experiences with various types of cessation-related tools. And you can see here that the majority of individuals use nicotine patch or a variety of nicotine replacement therapies. Only one person reported using bupropion. So varenicline and bupropion are pharmacological therapies that have been shown to help people quit smoking. And when I presented this data hospital-wide, as it turned out, the pharmacist was in the room when I was presenting this data, and they actually, asked me a question in front of everybody afterwards, or made a comment and said, actually, the reason I don't prescribe these medications is that it's dangerous for people with other substance use problems to take these medications. Well, fortunately, the chief physician of the hospital was there too, and very rightly corrected her that, in fact, there's a huge study, that EAGLE study that came out that actually shows that these medicines are effective for people with substance-related problems and not more dangerous. So it's just kind of give you like an individual level, like systems understanding of, treatments that aren't being provided when they could be, and why they weren't in this case. So something that I thought was really great to see is that the smokers showed significant reductions from admission to discharge in their cigarette craving. So we measured their current craving as well as their peak craving in the past week. And just being in this tobacco-free environment for a 2-week period resulted in significant reductions in their craving. There was also a significant reduction in their nicotine withdrawal from admission to discharge. Now, when looking at attitudes related to the tobacco-free policy, here I have the data combined for smokers and non-smokers, and that's because there was no statistically significant difference between their attitudes. So the smokers and non-smokers reported very similar attitudes about the policy. And by and large, they were very positive. So the majority agreed that rules on smoking are respected by patients. The majority disagreed that tobacco smoke is a source of conflict between patients. And most disagreed that it was a conflict between patients and staff, and most people disagreed that it was hard to have smoking and non-smoking patients living together. So people generally were reporting favorable attitudes about the acceptability of such a policy. Adherence, so I didn't have any sort of objective measures of adherence, like a carbon monoxide reading that could, independent of self-report, determine if people were adherent or not. So I'm really basing this on whether people were willing to tell me that they were not adherent. But this was an anonymous survey, so I would hope that they would have been honest in this context. But 16% of the smokers did say that they smoked at least once during their admission. So even though it was tobacco-free and a closed unit, they managed to smoke in one way or the other. In terms of like an indirect measure of adherence, I also asked people about secondhand smoke exposure, seeing that might be a proxy of whether people are smoking around them without ratting themselves out. And most people reported no exposure to indoor tobacco smoke, but there was still about 13% that said people were smoking indoors. Most often people were exposed to tobacco smoke outside. And it's hard to know exactly what the circumstances of that were. Were they fellow inpatients that were smoking? Were there other hospital patients smoking while they were outside and they just passed by them? But that being said, this is an issue because it's a tobacco-free hospital campus and people are still getting exposed to secondhand smoke outdoors. Okay. So in terms of quitting interest, I mentioned there was a high interest incoming for patients to quit smoking. Well, when people were discharged, 58% reported that they could plan to continue to abstain from smoking. I don't have follow-up data to see if they were actually able to do that. We actually tried to collect that data, and it was very hard to reach people after they were discharged. And about half of them said that they would seek help for continued assistance to help them quit smoking. So just to put that all together, cigarette smoking is prevalent among people, at least in this hospital sample, receiving treatment for other addictions. And in this case, it was actually associated with more severe alcohol problems and more severe mental distress. We also saw that overall 65% of people who were admitted for other substances were also tobacco smokers. And I would argue, it's not just based on this data, but other data that has been published, that really inpatient addictions treatment may be an ideal opportunity to try to help people quit smoking, especially because many of them are coming in, they're already interested in quitting smoking, and they have the medical assistance to try to do so. Okay, so moving forward about some of the tobacco-related policies, and how that might impact alcohol use. Coming to Oregon, I've been tracking really closely before I came here the increase in the smoking age to 21. And I think this would be a really great opportunity to see whether that change in smoking age has any repercussions on other substance use. That's something, if people are interested in collaborating in, I'd really love to. The other thing I'd like to address in my future research is that we're still lacking on empirically supported treatments and guidelines for providers to help heavy drinking smokers. So there's still this question of, is it better to intervene with both at the same time, or maybe a staggered approach, or there's certain interventions that work better for co-users than single users. So I want to try to address these questions in a number of different ways. One thing that I'm proposing to do in a grant application is to try to make use of community samples in order to try to understand how we could evaluate various treatment options. So for instance, I'd like to recruit heavy drinkers from the community and simulate alcohol intervention. So basically pay them to be abstinent for an extended period of time. You see here a SCRAM bracelet. So this is a device that can measure transdermally whether people are drinking or not. So I'd have a very good sense on a moment-to-moment basis if people are drinking or not. And then look at how it affects their smoking. So how does it affect their smoking from day to day? How does it affect their smoking in the laboratory? I've used the simulated smoking lapse paradigm where you can try to mimic the experience of quitting smoking in a relatively short period of time to try to evaluate whether interventions are helpful or not. And part of this work would be continuing to look at what are some of the psychological and biological mechanisms linking cigarette and alcohol use. So I recently finished collecting some data that has exhibited that people receiving treatment for alcohol use disorder actually shows substantial changes in some nicotine-related biomarkers that are known to influence one's ability to quit smoking. So specifically, people who are in treatment for the alcohol use disorder, as they reduce their drinking, it appears that their nicotine metabolism is also reducing. And that's even though they're not altering their smoking behavior. But might this be an opportunity then to coordinate treatments? Because we know people who have lower nicotine metabolisms tend to respond better to things like nicotine replacement therapy. So I'm hoping to use these types of designs to try to evaluate that. The other research that I'm in the early stages of doing is, again, trying to better understand this idea of synchronizing treatments and using some pre-existing data to look at this using some quantitative tools that are specifically suited to look at these potentially time-varying effects. So, for instance, we know that on average, people who are trying to quit smoking, if they drink, they're more likely to lapse. So alcohol use makes it harder for people to quit. But what we don't know is this like a universal issue across the entire quit attempt? Like, do we have to recommend to smokers to stop drinking forever? Or is it maybe just a critical period of time that they need to stop drinking? And maybe that would be medical advice that they'd be more willing to accept if it's just like a short-term change. So using this model, what I want to look at is I have data from smokers who are trying to quit smoking over several weeks, and I have daily measurements of their alcohol use, and look at over the course of the quit attempt, when is alcohol actually predicting smoking lapses. So these are some of the collaborators on this research and the grant funding that was responsible for what I was able to present to you today, and some of the students that have been involved in this work. I'm happy to take questions. Thank you for your time. Yes?
Those of us who like beer know that you can go in a bar and get a 3% beer, a 7% beer, a 12% beer. What do you define as heavy drinking? What do you define as a drink?
Yes. So when measuring daily drinking, we use the convention of a standard drink, which is about an ounce of alcohol. And so we actually present to the participants this chart that shows, what a glass of one standard drink of wine, beer, and liquor looks like. And then when they are talking about, craft beers that have 7 or 8% alcohol, we do try to adjust with our calculations. When I'm talking about high-risk drinking, it can be defined a few different ways. So we talk about binge drinking, so that would be 4 or more drinks in a sitting for women and 5 or more for men, using that standard drink convention I just described. And then high-risk drinking can be defined as doing that at least 5 times in the past month. And then, depending on the country, that they have other guidelines. Like I think in the U.S., it's for women, more than 1 drink a day is considered unhealthy, and then for men, more than 2 drinks a day is considered unhealthy. Yeah. Mm-hmm.
So I was surprised to see that the use of the very low nicotine cigarettes is related to less cigarette smoking. Wouldn't it be the case, well, maybe there was some subset of smokers, if they're really addicted, then to try to get more nicotine, they would like smoke more cigarettes? I mean, wouldn't you expect that? And is there some subset of people that increase their smoking in order to maintain the level of nicotine?
Yeah, so a while back there were light cigarettes that had slightly reduced nicotine levels, and when those were introduced, we actually saw that people would compensate and they would smoke a lot more in order to get more nicotine. The difference between the light cigarettes and these VLNC cigarettes is that the nicotine is so low that it's almost impossible for people to smoke enough to compensate. So what we did see is that there's an increase in smoking in the first 2 weeks compared to people's baselines. And that might be a period of time where people are trying to compensate, but just through learning theory, they're seeing that it's not working. And then we see a subsequent decline in their smoking because the cigarettes are not delivering a sufficient amount of nicotine. Yeah.
Sarah, this is really interesting. Is there enough data on these low valence cigarettes that people are actually using that in cessation treatment?
Yeah, so I know less about people using it as a cessation tool. There was a study that used these cigarettes with people interested in quitting smoking. So actually the study I just talked about, everybody didn't want to quit smoking. So we saw a reduction even though they weren't trying to quit. But for people who do want to try to quit, they had them smoke them for 6 weeks and then do a quit attempt at the end. And they did see that people had an easier time quitting smoking when they had 6 weeks of smoking those cigarettes than people that were smoking their regular cigarettes. Yeah. Mm-hmm.
I just sort of want to signal, sort of building on what Mark was saying, when this idea came out as a sort of national approach to addressing the problem of tobacco addiction, there was a ton of outrage, how could you do that? That's an incredibly radical idea. And a lot of people have that same concern. People are just going to compensate, right? They're just going to smoke a lot more, which means they'll be exposed to all the garbage. Because it's not the nicotine we're worried about in the cigarettes, it's all the viralized tobacco.
Right.
That's really causing the harm. And, but this is the first time I've actually seen a study that shows that you could feasibly do this as a strategy for a population level, addiction treatment, essentially. So
right.
It's pretty, I hope that your paper and your work gets a lot of promotion because it seems really important.
Thanks. Yeah, it's an understandable gut reaction to think about the compensation, and there have been a number of papers really trying to focus on that. Even in a laboratory context where they really can get a more fine-tuned look of puff topography to look at compensation. They see with the first cigarette smoked that there's some more intense puffing, as a form of potentially compensating. But by the fourth cigarette that's smoked in that context, people are smoking as if they would be normally smoking. Yeah, they give up.
Encouraging.
Yeah.
I know you said you weren't going to talk about this, so I'm going to ask you about it. You said you had done work with sexual minority youth and tobacco, and we know their tobacco use is much higher than, or at least the young adult period is much higher than sort of the general population. Can you talk a little bit about or some highlights of your work with that population? Yeah,
so most of my work in that addressing that issue is more using epidemiological data sets to kind of describe the patterns of disparities, and specifically not just trying to understand the tobacco-related disparities, but also taking it in the context of other substances. So I recently finished a paper with the YRBS that showed that basically, and it's not surprising, I guess, that there was actually no pure nicotine-using group of youth. By and large, people were using nicotine and alcohol, or nicotine and marijuana, or nicotine with alcohol and marijuana. And what I was finding is that sexual minority youth were at a greater risk of being in those co-using groups than heterosexual youth. So to me, it just kind of suggests that when we're trying to think about it from an intervention approach, to just tackle tobacco use in of itself, while it would have like a health benefit, we need to take the broader context into account that these youth are also having difficulties with these other substances. So in the future, I'd like to get a better sense of the mechanism. Like the prevailing theory is that it's a minority stress model that's contributing to these types of disparities, but there isn't a lot of data that's really examined that in the context of polysubstance use.
Thanks.
Yeah.
One more question. Oh,
Well, I don't want to. When you're describing your first study, I mean, I was trying to picture the clinical setting, and it seems so odd, you know, when you're looking at the relationship between alcohol use and cigarette use. So did you just kind of like set people up and say, here's a controlled amount of alcohol, and here's the cigarettes, have whatever you want, and vice versa, here's a controlled number of cigarettes?
Oh yeah, those laboratory studies.
Here's an open bar, just drink.
Yeah, so they're really variable. They run from like being like really like ecologically valid to like being really obscure. Like they have one study where people actually administered nicotine and alcohol intravenously to look at the interactions. But then you have other studies where it's more prototypical, like having people smoke a full nicotine cigarette versus a very low nicotine content cigarette. They're blind to what the condition is. And then you present them with alcohol and they can drink freely.
What they want though, right?
Yeah, but
They're looking at free use.
yeah, so some of them do free use. Some of the studies do a set amount of alcohol use just so that you can look at interactions on like the drug effects at a set dose. So the studies, there's like a lot of variability in what the studies do, which is helpful in some ways because we can get different sides of the story, but it's really difficult when the studies don't replicate the findings because then we don't know what variable is contributing to that.
Time for one more question?
somebody else go, because
Yes.
So given the variable outcomes and studies of the health effects of caffeine, how did you decide, or how do people in your field decide whether or not to include that in, you know, like for example, the list of drugs that people are using in the hospital?
Yeah. Caffeine is an understudied substance, believe it or not, even though it's like so widely used. So in this very low nicotine content study that I described, we didn't even measure caffeine use. It was kind of like an afterthought of, oh wow, we really should have measured that.
No, I'm asking about your field, not particularly about you.
Yeah. No, I mean, it's a broader thing in the field that people don't tend to look at. I mean, there are people that look at caffeine and other drug interactions, but, you know, in the research areas looking at alcohol and nicotine, I haven't seen anybody add the layer of caffeine onto that. That being said, I know that there's research to show that caffeine and tobacco use really go hand in hand. And, you know, with the advent of alcohol-containing energy drinks, there's higher risk associated with that. But that's about all that I know. Yeah.
Thank you.